to Partners in Pancreatic Cancer. I am Dr. Bekaii-Saab. I am frequently asked what factors need to be taken into consideration in selection of first-line treatment for patients with advanced metastatic pancreatic cancer. Today, more than ever, we have more options available to our patients with pancreatic cancer. And these options are available across multiple lines of therapy. It is interesting that in pancreas cancer, we are talking about multiple lines of therapy. For multiple decades, we've barely had one line of therapy, mostly ineffective, 5-FU, and then gemcitabine, and then for some patients, they would go to 5-FU in the second line. Spend a lot of time and energy and resources looking at combination therapy with gemcitabine plus drug X, and looking at various biologics, mostly with futility. Lately, after the year 2010 at least, we're starting seeing more activity with regimens that are more active than gemcitabine. So FOLFIRINOX first, then gemcitabine, nab-paclitaxel as a combo. Then in 2015, we had the combination of 5-FU and a nanoliposomal irinotecan, MM398, that made its way into the second line for patients who failed gemcitabine-based regimens in the first line. So this armamentarium went from just single-agent gemcitabine now to 3 options, 2 in the first line, 1 in the second line. And then we also had more data with oxaliplatin and 5-FU, which had been considered for quite a while as a standard for our second line. So how do we actually put all this together? How do we think about, okay, who is that patient who should get FOLFIRINOX? Who is that patient that should get gemcitabine and nab-paclitaxel? And then who is that patient who perhaps should get gemcitabine or no therapy? So let's start with the no therapy / gemcitabine. Here, the way to decipher which patients should not get treatment or should get single agent gemcitabine are those patients that we consider with a very poor performance status, 2+, 3 or 4. So 3 or 4 should not get treatment. Performance status 2, probably bordering the 3, should not get treatment. But those performance status of 2 bordering the 1, and those are patients that have a lot of pain that's limiting rather than being limited by other factors. Those patients may benefit from gemcitabine plus minus perhaps a nab-paclitaxel. Most of the patients we end up treating are performance status 0 and 1, and maybe between 1 and 2. So for those patients, the question is, how do you choose between FOLFIRINOX and gemcitabine nab-paclitaxel? The general rule that has been followed in the community and academic practices is your best patients, those that have the best performance status, they're younger, they're healthier, you place them on FOLFIRINOX. Those that are less performant, perhaps older, you place them on gemcitabine nab-paclitaxel. Well, while that could make sense, and FOLFIRINOX is certainly a regimen that has a meaningful activity, it is aggressive and it has toxicities. The importance of understanding how to select those patients for FOLFIRINOX versus gemcitabine and nab-paclitaxel, while clearly FOLFIRINOX is a very aggressive regimen that seems to provide tremendous benefit versus gemcitabine, relatively speaking, for pancreas cancer, of course. The toxicities that come with it can be quite significant as well. And the fact that we have a second-line regimen, such as 5-FU and MM398 or nanoliposomal irinotecan, makes a stronger case to move our practices to a more sequential approach. I mean, if you look at lung cancer, breast cancer, even colon cancer, other cancers, we're moving more and more towards sequencing regimens rather than just an all-kitchen sink approach. So my preference has been more and more to shift patients to gemcitabine nab-paclitaxel in the first line, and then in the second line with 5-FU MM398, rather than that all-kitchen sink approach with FOLFIRINOX. I hear many times physicians saying, well, I only see strong solid responses with FOLFIRINOX. And that is true, and mostly because we have that selection bias. I mean, when we see, as I said, patients in our clinic, you're choosing the best performing patients who have probably the best biology and most likely to respond well to doublets or triplets to FOLFIRINOX. So there is this intrinsic bias. So I think a much better way to rethink how we treat pancreas cancer is to really focus on a sequencing approach with gemcitabine, nab-paclitaxel first line, 5-FU-MM398, or nanoliposomal irinotecan in the second line, and that also still leaves us potentially in the third line to use oxaliplatin. Now, why is oxaliplatin now in the third line, whereby for many years we've used it in the second line? Because of now a series of studies that suggested, unlike the CONCO study that initially looked at oxaliplatin 5-FU and suggested a benefit, the studies that came from Canada and then more recent studies as well suggest that oxaliplatin perhaps is not, that is the SWOG study versus double biologic, suggests that FOLFOX is probably not as active as the irinotecan component, and therefore perhaps moving oxaliplatin now to third line, or even I personally rarely use it these days in clinic anymore. So I think these are important considerations when we're thinking about patients with in the first line treatment of metastatic pancreas cancer. Very importantly, last point, very importantly, patients who are suspected to be BRCA or have BRCA-driven pancreas cancer, those patients seem to actually have exquisite sensitivity to cisplatin at a lower dose. So those patients could perhaps be considered for gemcitabine cisplatin. They also could be considered for FOLFIRINOX, but those patients also respond well to irinotecan, respond well to oxaliplatin, and to cisplatin. This is about a small percent of your patients, but I think it's very important to keep an eye on those patients with a potential BRCA-driven tumor. So in sum, when we're thinking about our patients with pancreas cancer in the first line, we have to think about what makes the most sense. Try more and more to consider a sequencing approach, even in the well-performed patients, and then keep an eye on BRCA. Last word on gemcitabine nab-paclitaxel. There's a significant challenge with giving the weekly regimen, and we have actually published a recent paper on giving gemcitabine nab-paclitaxel every other week, so skipping day 8, maintaining the same dosages. We've seen very similar progression-free survival. Again, this was mostly retrospective, but the toxicity rate was tremendously improved historically. The grade 3 neurotoxicity rate with the every other week was less than 1% versus 17% with the weekly, and we had less growth factor support, etc. So that could be also another consideration for many of your patients as well, and keep it in mind as you're thinking about all these factors that will lead you into treating those patients in the first line. So thank you for viewing this activity.